So here is the key question now, right? After all these clinical trials, the question that you pose is, should you be then treating all patients? Should everyone with an LVO and a high NIH stroke scale undergo thrombectomy? And then the typical question is, answer to this question, if I ask Andre, he's gonna say maybe the majority, but not everybody. The answer is no. Then I'm gonna ask you why. Why the answer is no? And typically people you say because the procedure may be futile. And then I'm gonna ask you, how do you know the procedure is gonna be futile? And then you're gonna say, well, because we can do all this real cool image, and with this cool image, I can predict the outcomes. And that is true. Imaging is a predictor of outcome. It does that reasonably well, but imaging does not nullify the benefit of thrombectomy. Therefore, imaging should not be used to exclude patients from treatment alone. We're gonna get that to the very last slide, why you still can use imaging in your decision-making process, but please be humble. It tells you prognosis. We don't really know very well what completely nullifies the benefit. And here is a proof of concept. This is a study that was done at the place where I trained and worked for the first 5 years of my career, Mass General Hospital. Sophisticated people, they were given clinical imaging scenarios of patients that were going to undergo thrombectomy, and they were asked a simple question. With this clinical scenario and with this imaging, I want you to tell me if this patient is gonna have an MRS 0 to 2, or 3 to 4, or 5 to 6. And they were wrong over half of the time, okay? So worse than flipping a coin. That essentially tells us that we are not God. We don't know what's going to happen to these patients. And then, if you want to talk about futility, please educate yourself first. Futility is an unacceptable likelihood of achieving outcomes, that it's deemed by the patient, and in the absence of the patient opinion, it's not your opinion, but rather the opinion of the family. If you have to put a number on that likelihood, it's less than 1%. Moreover, do not confuse medical futility with healthcare rationing. You're not talking about cost effectiveness here. You're talking about no chances or almost no chances of a good outcome that in the opinion of the patient would justify doing an intervention. So I think this pretty much buys the patient the benefit of the doubt, most of the time, if not invariably. And it's cost effective, by the way. If you want to look at cost effectiveness, even in large core trials, it's pretty much unanimous. Every time you look at the cost effectiveness of thrombectomy, we see a benefit. By the way, I'm still waiting for the cost effectiveness analysis of the IRIS trials. I haven't seen those yet, right? We keep talking about withholding thrombectomy. I have no problems giving thrombolytics prior to thrombectomy, but you should study the cost effectiveness of that. So let's talk about the decision-making thrombectomy. Why things have gotten so complicated. We have made tremendous mistakes along the way. In order to not make the same mistakes in the future, you have to understand the past. And here is the past of intra-arterial treatment of stroke. It starts so beautifully. It goes back to 1958 with this paper from Sussman and Fitch. And they inject plasmine in the carotid artery, some cases of ICA and MCA occlusion. This actually dates back, it's actually 2 decades prior to Andreas Grütznik publishing in coronary intervention for stable disease. STEMI actually came later. So we start 2 decades first. And how come you got so behind cardiology, right? Part of the problem has to do with the original sin. We commit the original sin. As you're trying to climb the tree of evidence-based medicine, you went for the low-hanging fruit, which is the single-arm trial. Cardiologists, on the other hand, they, since the beginning, very, very early, I should say, that randomized clinical trials, that has a tremendous implication on the understanding and the decision-making process, as I'm going to explain here. So we almost did some good trials, PROACT-2 and MELT. They were small trials, right? And they gave us important answers, but after that, everything was open label, single arm. And then you had polarization, people like me that were writing, listen, you recanalize a lot more, it's good to have an open vessel. And other people, like Dr. Powers, are saying it's bad, you're just gonna have bleeding, look at how much bleeding. And then there were all these controversies, but what is key to understand is the difference between prognosis and benefit. So let's talk about this, okay? You have to understand the differences between predictors of outcome and treatment effect modifiers. So let's walk through the history here. We start with single-arm, uncontrolled trials. When you have a patient with a thrombectomy, you're comparing a patient with a thrombectomy, different characteristics, and we all learn, oh, being old is bad, sure. Having a large infarct is bad, sure. Being treated at later times is bad. Okay. But now, and that's what cardiology had since the beginning, we have randomized controlled trials. So you can now finally compare similar patients, similar characteristics, one to another. And then we have understood that age, infarct size, and time do not change the benefit of thrombectomy. They are not treatment effect modifiers. But those things are rooted in our minds. We think about prognosis. We don't think about benefit, right? About treatment effect. Predictors of outcome answer this question, who does well with treatment? But what really matters is this question here. Who does better with treatment than without treatment? That's what matters. Can I make you better? Sometimes you are too far gone. I'm not going to be able to make you well, but I can still make you better. So that's where imaging comes, because it's great for prognosis, and you always want to have a good outcome, a good prognosis, so you want to use imaging. Remember this, the difference between medicine and poison is in the dose. Imaging is great, but do not misapply imaging. Don't overuse it to exclude patients from treatment. That's where the mistake is. More imaging, more information, which is great, but remember, also more time. And then you're gonna talk about the fact, oftentimes, it's not only information, it has been used to cause misinformation. And that's one of the biggest problems that you have with imaging. Don't get me wrong, I love imaging. I've written much about perfusion, I think it's very cool. And it has its application, I believe so far, with intravenous thrombolysis in the extended window. It seems to be a treatment effect modifier. If you look at this great paper from Bruce Campbell and colleagues, you see that in the extended window thrombolysis, you only have a benefit, right? If you apply advanced imaging. Completely okay with that, but as you move this topic to thrombectomy, and here is the Hearns analysis, okay? There isn't a single imaging variable there that has nullified the treatment benefit, right, of thrombectomy. Not a single one. Yes, they are predictors of outcome, but they are not treatment effect modifiers. So you shouldn't be using these things to exclude patients from treatment. Not alone. We're gonna get to the part of this at the end. What is the net result? We are over-selecting. I love this, okay? If you look at this, it shows better imaging, right? Mr. Clean, just non-contrast CT, then CTA, escape some collateral use, and then perfusion, extend more perfusion. As you do more imaging, look at what happens. Better outcomes in the treated patients, right? But also better outcomes in the control patients. So that doesn't translate in a higher benefit, and you're gonna say, how you are wrong? It actually does, because 71 minus 40 is 31, which is a higher number than 33 minus 19, which is 14, right? So it's a higher treatment effect as you do more imaging. The difference is also bigger, right? Wrong. Do you know why it's wrong? Because that's the denominator fallacy. Let's move to this experiment here, okay? 100 patients in 2 hospitals. Hospital A is a very cool hospital that uses CT perfusion. Australia, Extend IA, best results ever. They select these patients, and then you have a number need to treat of 3. This is better than antibiotics in sepsis, by the way. And the rates of good outcome at 90 days is 70%. This is absolutely amazing, right? Well, this is a more pragmatic approach, like, let's say, Mr. Clean, just a plain CT. And they treat a bunch of people, and then the number need to treat is 5, and half of what they saw in the other side, only 35% achieve good outcomes. Everyone has to vote, okay? Do you want to go to hospital A or hospital B as a patient? So who wants to go to hospital A? Raise your hand. Hospital A? All right, okay. Who wants to go to hospital B? Raise your hand. Okay, more people. I like that. A bunch of people are not going to either one. You're gonna get a hemicraniectomy tomorrow, okay? Because you didn't get thrombectomy. But let's go through this. This is the denominator fallacy. As you look at outpatients, okay, 10 out of 100 patients benefit here. Versus here, as you look at outpatients, 16 out of 100 benefits, 60% more. You have to understand that our duty is not to the lucky people that we decide to treat, but rather to the entire population that you evaluate for treatment. And that's one of the biggest problems. We don't compute in our statistics everyone that you said no to. And that's absolutely ridiculous. You can't look at your outcomes in the patients that you did thrombectomy. You have to look at the outcomes of everyone that you could have done a thrombectomy. And same thing applies whether it's imaging, no imaging, more imaging, less imaging, smaller course, larger course. The other point here is that measures of infarcts are imperfect, and that applies to both the quantity, which is the thing that everyone gets, but infarcts they don't have only one dimension of quantity, they also have a new dimension of quality that you have to understand. And let's look at what perfusion does. I like to say CT perfusion, diffusion with reperfusion equal to confusion. And here is a good example. Big mismatch, not really, right? Because you have this big pink area, beautiful time density curves, by the way. We treated this patient because the CT looked good. This is years ago. Look at what happened. Here is the DW line. So it was a fake core. Mark Rebo baptized this as the ghost core. It's very common in the early window, okay? But it just shows that CT perfusion, it's not that brain, okay? It's hemodynamic imbalance. It shows you hemodynamics. It does not show you histology. So do not exclude a patient with a good-looking CT and a bad looking CT perfusion. Okay, you can't do that. Remember, it's not histopathology, it's just hemodynamic failure. Okay, you can still reverse that. How about DWI? Here is a DWI. Actually, in a patient that I know, I see occlusion, you can do your aspects, and whether it's a 2 or 3, you can debate until tomorrow. But the fact is, the patient was treated, and even the diffusion reverses. And this happens in at least 10 to 15% of the cases. Okay? So, what is DWI? It is not histopathology, it's not that pain, it's bioenergetic failure. You can reverse that. So there is a lot of self-fulfilling prophecy in imaging. You have to remember that some of the large chords in these trials were just estimated large chords that were not real infarcts yet. What is the data? I'm not here to talk about the data. I'm trying to give you more like a philosophical approach to treatment. There are these 6 trials.